Now our lecture today is facial space infection. As I mentioned in the previous lecture, that odontogenic infection may spread to the soft tissue surrounding the jaws. And could be manifested clinically either as infection in the labiobuccal vestibule or in the facial spaces surrounding the jaws. Actually, this is determined by the muscle attachment or the relationship of the root of the tooth to the muscle attachment. In this lecture, we are going to discuss the infection of facial spaces in relation to the lower jaw, or what we call mandibular facial spaces, which includes submental space, sublingual space, submandibular space, submassetric space, or sometimes called massetric space, and ptyregomandibular space. Let us start with submental space infection. Submental space contains submental lymph node and anterior jugular vein. The etiology or the source of the infection from the infection of lower anterior teeth, but also the infection in the central portion of the lower lip, tip of the tongue, anterior part of the floor of the mouth, infection in the skin of the chin, and infection of other spaces may spread to submental space as well. Patients with submental space infection usually present clinically with red, hot, painful swelling in the chin. The patient complains of difficulty in swallowing and talking. The management of submental space infection includes surgical treatment and medical treatment. Surgical treatment by making a transverse incision below the chin and by insertion of mosquito to open the locules and then insertion of rubber drain for evacuation of pus. Medical treatment include antibiotic administration, bed rest, rehydration, and analgesia. Submandibular space infection, actually submandibular space contains submandibular lymph nodes and submandibular salivary glands. The etiology or the source of the infection usually from the infection of lower molar teeth, particularly pericornatus of lower wisdom tooth, but also infection in the lateral border of the tongue or posterior portion of the floor of the mouth or maxillary sinus, or sometimes if there is infection associated with the fracture angle of the mandible, or sometimes indirect infection from other spaces may spread to submandibular space as well. Patients with submandibular space infection usually present clinically with hot, red, painful swelling in the submandibular region below the lower border of the mandible. Sometimes also there is mild to moderate trismus, inability to open the mouth. Surgical treatment of submandibular space infection is by making incision parallel to the lower border of the mandible and 2 to 3 fingers away from the lower border of the mandible. Medical treatment by administration of antibiotic, bed rest, analgesic, and rehydration. The sublingual space infection, actually the sublingual space situated between the mylohyoid from below and the mucous membrane from above. This space contains sublingual salivary gland and duct of the submandibular salivary gland. The etiology or source of infection from the periapical or periodontal disease of the first and second lower premolars. Also, the periodontal abscess of lower canine or central incisor may spread rarely actually to this space. Spread of infection from other spaces to this space may occur as well. Before I discuss the clinical manifestation of patients with sublingual space infection, I would like to mention that the attachment of mylohyoid muscle determines the spread of the infection either to the submandibular or rarely to the sublingual space. That means the infection of the molars of the lower molar teeth determined by the attachment of the mylohyoid muscle. This is in the lingual side of the mandible. So mylohyoid muscle determines the spread of the infection of the lower posterior teeth either to the submandibular or to the sublingual space. Patients with sublingual space infection usually present with intraoral swelling. The swelling usually in one side of the floor of the mouth in the anterior region. The swelling may raise the tongue and the patient complains of difficulty in swallowing and talking. Enlargement of submandibular or submental lymph nodes could be seen or may be seen as well. The treatment or the surgical treatment is by making incision lateral to sublingual pellicle or what we call sublingual duct. Also insertion of mosquito and rubber drain for evacuation of pus. Medical treatment could be advised as well. Submassetric space infection. The submassetric space situated between the masseter muscle and the external surface of ramus of the mandible. This space contains blood vessels. The etiology or the source of the infection from the infected lower molar teeth, particularly pericornitis of disto-angular, impacted or partially erupted lower wisdom tooth. Sometimes infection of buccal space may spread posteriorly to submassetric space as well. Patient with submassetric space infection usually present with painful swelling confined to the masseter muscle, here to the masseter muscle. This is because the masseter muscle has heavy attachment to the external surface of the ramus of the mandible. The most important feature here is that the patient has severe trismus. The surgical treatment includes either intraoral incision or extraoral incision. Intraoral incision by making incision at the lower anterior part of the ramus of the mandible and by insertion of mosquito laterally between the ramus of the mandible and masseter muscle, or extraorally behind the angle of the mandible and by insertion of the mosquito laterally between the masseter and the ramus of the mandible. Medical treatment, antibiotic administration, analgesic, rehydration, bed rest could be advised as well. Ptyregomandibular space infection. This is where we give inferior alveolar nerve block. So the infection spread to this space from odontogenic infection, particularly pericornitis or periapical infection of lower third molar, sometimes infected needle during giving inferior alveolar nerve injection. Gunshot wounds or compound fracture, orthodontic surgery or spread from other spaces may spread to pterygomandibular space as well. Patient with pterygomandibular space usually present clinically with severe trismus, but there is no swelling, neither intraoral nor extraoral. Patient may complain of pyrexia as well as malaise. The surgical treatment also could be intraoral or extraoral incision. Intraoral incision by making incision at the lower anterior part of the ramus of the mandible and by insertion of mosquito medially between the medial pterygoid and the ramus of the mandible, or extraorally behind the angle of the mandible and by insertion of mosquito medially between the medial pterygoid and the ramus of the mandible. Rubber drain could be inserted, and medical treatment include rehydration, antibiotic administration, analgesic, bed rest could be advised as well. So this is the end of the lecture, and thank you for your attention.